Welcome to another PrecisCa tumor board. Great to have a world-renowned faculty to discuss these cases. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and a thoracic medical oncologist. And again, joined by a wonderful group of faculty. I'm going to allow them to introduce themselves. We'll start with Dr. Bala.
I'm Sanjeev Bala. I run the cardiothoracic imaging section here at Washington University in St. Louis. It's good to be here.
My name's Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and Professor and Director Emeritus of the Winship Cancer Institute of Emory University.
I'm Varun Puri. I'm a thoracic surgeon and professor of surgery at the Washington University in St. Louis, along with Dr. Bala.
I'm Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado. I'm a medical oncologist and delighted to be here again.
This is a 60-year-old Caucasian male, current smoker, 90 pack year history. Status post-right thoracotomy and upper lobectomy for stage 1 T2N0, moderately differentiated squamous cell carcinoma. And the question that we're all going to try to answer are any adjuvant therapies necessary, and how should surveillance be performed longitudinally? So the patient presented with cough, chest pain, and hemoptysis, has a preserved performance status with an ECOG 0. Medical history includes obesity, depression, anxiety, his social history, current tobacco use, 90 pack year history, no alcohol or drug use. Family history is consistent with lung and breast cancer. In terms of his oncology history, his CAT scan was done June 2021, and we'll go over those images, but this prompted a right bronchoscopy and a right upper lobe biopsy that was consistent with squamous cell carcinoma. The PET scan in July 2021, 1 month later, was done, and we'll review those as part of the staging. The patient does undergo a right thoracotomy and sleeve right upper lobectomy. The final stage is a T2N0, 4 centimeter, moderately differentiated squamous cell carcinoma. 0 out of 17 lymph nodes are positive. And interestingly, even though this is a squamous cell, there's an ALK gene rearrangement identified, and we can certainly talk about the relevance of this, how this was tested, and how common we see this in squamous cell lung cancer. So I'm going to turn it over to Dr. Bala to go over these images first.
Great. So the images from the chest CT on lung windows show an area of right upper lobe collapse. And on the second image, you can see that there's the takeoff of the middle lobe bronchus, but the upper lobe bronchus is completely opacified. And so we can't really see very much there. And that's pretty typical for a lobar collapse from a neoplasm. It can be very difficult on CT to distinguish the primary lesion from the subsequent collapse.
Okay. And this is just the bronchoscopy, right bronchoscopy that was done, showing you the lesion in the right upper lobe bronchus. And then we'll move on to the PET. Back to you, Dr. Bala.
And so the PET, FDG PET CT shows the uptake, and you can see that central lesion that's about 4 centimeters with a lobar collapse. And there's a little bit of uptake on the second image, which is probably just a little bit of post-obstructive pneumonia or a little bit of pneumonitis distal to the lesion. But the main finding is the central lesion, and there's no mediastinal lymphadenopathy or hyaline-lymphadenopathy that has uptake.
Okay. So clearly on PET, looks like an early stage disease. We don't have an EBUS for a mediastinal assessment, I don't think, at least in the case. And I don't think there was an MRI of the brain performed either. We can talk about the relevance of this and staging for early stage lung cancer. So the question is, are there any adjuvant therapies necessary, and how should surveillance be performed? And I guess this first gets punted to you, Dr. Camage. We've got a early stage lung cancer. I'm just going to go back, a T2N0, stage 1A. It's a 4 centimeter tumor. Interestingly, ALK gene rearrangement positive, but no nodes positive, at least with the surgical resection. So how would you manage this case as a medical oncologist?
Well, so the textbook answer is a 4 centimeter lesion. You would at least have the discussion about adjuvant cisplatin-based chemotherapy. But there's a lot of details here that we'd need to unpack. So first of all, one would like to know how well the mediastinum was staged. One would also like to know how the diagnosis of squamous cancer was made. There's no immunohistochemistry reported here. that ALK gene rearrangement, although it certainly can occur across histologies, seems extremely surprising in somebody who's a current 90-pack-year smoker. Someone would like to see whether that was spurious or not. Let's take certain assumptions here. So let's assume that they have effectively sampled the N2 stations, and Dr. Puri can talk through how maybe they might have done that. And let's say this really was just a 4-centimeter lesion within the lung. I think there, when you're, you know, this gentleman is pretty old, you can talk through their fitness to tolerate the chemotherapy and what you hope to achieve. What you hope to achieve is to improve their chance of cure by an absolute value of about 5%. What is their chance of cure given what we already know? Well, maybe it's as high as, you know, 75, 80%. You know, you can get slightly different statistics depending on where you look. And the patient may say, look, I'm just going to take my chances. Or they may say, I'm a fantastically fit 90-year-old. I have fantastic quality of life. I'm going to do everything I can to live to 98.
Okay. You know, I had medical oncology bias here when we started with this case, and I was thinking to myself, what would I do? So I pitched it to Dr. Kamich first, but Dr. Puri, you know, perhaps as the surgeon, you can talk about your approach on this case. Is it a reasonable approach based on what we're seeing here for an early stage lung cancer? Would you have assessed the mediastinum first, either via EBUS or a MEAD? How would you approach this case? And then we can kind of go back and switch this case up a little bit.
Thanks, Dr. Levy. Those are excellent questions. Can I request you to go back to the slide which had the bronchoscopy images in it, please? Right there. Excellent. So my approach in this patient who has a central tumor and who we think has a squam would be to surgically stage the mediastinum either with an EBUS or with a mediastinoscopy. And also at the same time, I would assess what's happening bronchoscopically. Here on the image on your left, you see the very proximal right main bronchus. It shows that you're looking down the right side and the membranous airway is seen from about 2 o'clock to 6 o'clock on the right side of the screen. And the rest of the airway is the cartilaginous part of the airway. And you're looking straight down into the bronchus intermedius, which gives off the middle lobe and the lower lobe bronchi. At the very top of the screen on the image on the left, you see that the right upper lobe bronchus is completely occluded. And on the right side, you see that the tumor in close view of the right upper lobe bronchus. It's important at this point to assess what margins one would be able to obtain at the time of doing an operation. So in this particular instance, one would make sure you take biopsies from the right main bronchus proximal to the takeoff of the right upper lobe bronchus, and also take biopsies from the bronchus intermedius distal to the takeoff of the right upper lobe bronchus, with the expectation that if you want to do a parenchymal preserving operation, that means you want to do a sleeve lobectomy whereby you will remove the right upper lobe of the lung and reattach the bronchus intermedius, which is what you see on the left side of the screen, the open bronchial orifice, to the right main bronchus, you need to have negative margins in both directions. And it would be important to have that assessment preoperatively and also confirm that intraoperatively with frozen sections from rings of mucosa on both sides when you're performing the operation. So I think staging the mediastinum is critically important, and having a good preoperative assessment and a clear surgical plan is equally important. I would also agree that a brain MRI or some sort of cross-sectional imaging of the brain in someone with a T2N0 central lesion would be indicated. And finally, to address the point of adequate mediastinal lymph node staging intraoperatively. It is important for all lung cancers, but particularly important in squamous as well as central tumors. The guidelines have changed over the last several years. So if you go back to about 8 or 10 years, the general discussion in either research papers or soft guidelines from societies included you stage at least 3 N2 lymph nodes at the time of a lung resection. And then through with some literature, some of which published by our institution, it went up to 10 total lymph nodes resected at the time of the operation. And the current American College of Surgeons COC guidelines actually have been simplified. So they include 3 distinct N2 stations and 1 distinct N1 station being resected as part of every lung cancer operation. This is a relatively low bar. And I think that in this particular operation with 17 lymph nodes having been resected, although we do not have the distribution of which mediastinal and which N1 stations were resected, it is highly likely, particularly in the setting of a sleeve resection, that a more than adequate lymph node assessment was performed in this operation.
Dr. Puri, great overview. Maybe we can push this a little further and ask a controversial question, which is, if you were to go in and assess the mediastinum and you did find out intraoperatively that there was a single station N2 involved, would you proceed with the surgery? Would you back out and off, put it back to the medical oncologist for potential induction? What's your approach on this scenario, which I imagine does occur from time to time when you're in there?
Actually, that's a great question. But Dr. Levy, this is actually occurring less and less frequently now with excellent preoperative mediastinal staging, either with an EBUS, EUS, or mediastinoscopy. However, when we do find surprise N2, that is typically in the setting where we're doing an intraoperative assessment rather than a preoperative assessment of lymph nodes, and having chosen often a minimally invasive approach to doing the operation. So there are certain guidelines that are proposed in this domain. Most of those are based on very soft evidence and retrospective evidence. And my approach in this situation depends on what the incision is. Is there a thoracotomy that has already occurred, or is this a minimally invasive operation still? How many lymph node sites are showing N2 disease? And are there things that have already been conducted in the operation which are beyond the point of no return? So if the patient has already had a thoracotomy, in that case, most of the morbidity of a lung resection comes from a thoracotomy. And in that instance, if there is minimal N2 disease, which can be completely resected with negative margins, both for nodes as well as the primary tumor, my personal preference would be to go ahead and proceed and complete the resection. However, if there's an instance where the patient has a somewhat marginal functional status to start with and is undergoing a minimally invasive operation, and one finds more than one lymph node with surprise N2 disease, then in that instance, one would certainly think twice about proceeding with the resection. And my personal approach would be to back out, either to provide preoperative neoadjuvant therapy or refer the patient for non-operative therapy with definitive chemoradiation therapy followed by immunotherapy.
Okay. Great overview. And again, something that I think is controversial, and certainly in the eyes of the beholder and the surgeon and the multidisciplinary team, how these are managed. Dr. Curran, any thoughts on adjuvant radiation here for T2N0? Is there any role for radiation post-operatively in this patient?
Yeah, Dr. Levy, I see no indication. The only real time I would think about it would be if there was an incomplete resection of some type, or perhaps we had some indication that there was really an inadequate lymph node staging. If there was, for example, one of one lymph nodes harvested and there was imaging evidence of multiple lymph nodes being positive, we might consider. But in this setting where there's many negative nodes, great staging, complete resection.
Dr. Kamich, just one hypothetical here. This patient did not have an ALK gene rearrangement. Let's say this patient, uncommonly, EGFR is not very common in squamous cell, but let's say this patient had an EGFR mutation for resected T2N0 4-centimeter tumor. How would you manage that patient? Would you offer potentially an adjuvant TKI for a 1B tumor?
Yeah, I mean, that's a very good point. It is somewhat controversial. I think partly because our best data set, or at least our most prominent data set, is the ADAURA study, which was 3 years of osimertinib versus placebo. One would point out that in the ADAURA study, adjuvant chemotherapy was encouraged. The benefit was certainly more prominent in those with higher stage disease. And the controversy is that the primary endpoint was disease-free survival, which was assessed when most people were actually still on the drug, which is perhaps not surprising that it was positive. The reason that it upset some people was that this is assumed to have been a surrogate for overall survival, and certainly seems to have been presented that way. In fact, you can think about it in a different way. You can say, look, I don't really care if this is improving overall survival. What I'm really doing is I'm kind of, punting the ball down the field for 3 years and saying, look, you may not be cured, but you're probably not going to relapse if I put you on a pill for 3 years. And so it's a bit like putting the patient in a time machine and saying, well, worry about this in 3 years. For a 90-year-old patient, that actually sounds very reasonable, because there's a whole bunch of other things that might happen in that time.
Okay. So for the sake of time, we're going to move on, but all excellent points from each of you on this patient in particular, as well as additional scenarios. It sounds like, at the very least, a summary, that there is a discussion on adjuvant chemotherapy for this patient, but certainly, and Dr. Camish, correct me if I'm wrong, you wouldn't offer an adjuvant ALK TKI for this particular patient.
Well, the very first thing I would do is say, this is very surprising. I wonder if we could check that diagnosis by orthogonal testing. Was it done by immunohistochemistry or FISH, which could have a false positive? So I would just double check that first.
Okay. And if it were positive, and it did, and if it were confirmed?
Well, so it's almost like the discussion we just had about adjuvant EGFR therapy, except there's even less data because nobody's completed a study. I think if you want to go off-label, you could have that discussion. Equally, you could say, you know, we don't know that there's any data at all, and it will mostly depend on whether somebody's insurance would even entertain this as a possibility or what their self-pay might be.
Okay. So in summary, a discussion, potential recommendation for adjuvant platinum-based chemotherapy, and a discussion, potentially shared decision-making on the role of an ALK-directed therapy, if indeed the ALK were true and was interrogated by an optimal platform.